Welcome to the Childbirth Attorney podcast. I am your host, Gina Mundy. As an attorney specializing in childbirth cases, I have analyzed almost every aspect of labor and delivery for over 21 years. About 19 years deep into my profession, I made the decision not only to get involved in the aftermath of something going wrong, but to get involved before childbirth to help parents prevent the mistakes and complications I've seen and have a healthy baby. In June 2023, I published the book, A Parent's Guide to a Safer Childbirth. This podcast is a continuation of my book. It's a continuation of my mission to help parents have a healthy baby. Keep in mind, my book and my podcast is not about what can go wrong. It's how to make sure it goes right on one of the biggest days of your life. So whether you're expecting a baby, planning to have a baby in the future, or just passionate about making childbirth safer for all, this podcast is for you. So please join me as we start this journey for a safer childbirth.
But the best way to figure out how your baby is doing is their heart rate. That pain, it changes the state of mind you're in. It is your wife who makes the decisions during childbirth. The Childbirth Attorney Podcast, hosted by Gina Mundy.
Welcome to the Childbirth Attorney Podcast. I am your host, Gina Mundy. Today, I am so excited to introduce to you guys Kelly Hof. Kelly is a labor and delivery nurse. She also has an awesome podcast called the Birth Journeys Podcast. And the other one of my favorite things that she does is she is a birth coach. So, and not only is she a birth coach, but it's 100% remote. So no matter where you are in the United States, where you are around the world, Kelly, it's definitely something that you should look into. So without any further ado, Kelly, welcome to the show.
Hi, good to see you again.
I know. Oh, I love it. Why don't you tell everybody a little bit about yourself?
Well, I've been a nurse for about 10 years. I started off in postpartum, and then after that, I went to labor and delivery. And then since then, I've worked in every aspect of maternal health. So I've done special care nursery, I've done regular nursery, I've done maternal fetal medicine, labor and delivery, and postpartum. So every stage, except for being in the actual doctor's office, but maternal fetal medicine is basically a doctor's office. It's just for high risk. So pretty much every stage of pregnancy and birth, I've been working with for the past 10 years. And what I've seen is that nobody prepares for childbirth enough. And when you don't prepare enough, you don't feel confident advocating for yourself. So that's where I feel like I need to step in and fill in the gap, because it's really hard for me to coach someone through childbirth at the bedside when they have done no prep, or if they've done prep, it's only just been learning the things, not necessarily working on their mindset and advocacy and how they feel about all of the different options and interventions. So I've learned that if you do adequate birth prep, you can prevent birth trauma because you feel like you're in control.
100% all day long. I absolutely love that. And, on the podcast, I reference my book a lot. And, chapter 1, the lessons from the baby cases. Lesson number 1, you must prepare for childbirth. And again, as a lesson, we're learning from the past to help, prevent it from happening in the future. And that's why I absolutely love that your birth coaching class is remote. It's for everybody. I remember when I first learned about you and I looked at everything, and I remember, I think we were on your podcast. Actually, I think I was a guest on your podcast.
Yeah.
And I remember looking at you going, you are Gina approved.
Yes, I remember that moment too.
Yes. And you know what? I'm like, I think I've Gina approved one other person, but but no, I mean, I'm just so incredibly impressed with you. I have resources for expecting parents on my website. I have about 30 resources, I need to put up. My number 1 was you. I obviously got your stuff up immediately. Now we just got to get the other 29 up there. But no, I love
no small task.
I love, labor and delivery nurses play such a huge role during childbirth. They, you guys are the ones at the bedside, and, you're usually, are you guys communicating with the doctor, or do you guys have residents? Is it? Oh, you
We
are.
are. Yeah.
Yeah.
We don't have residents at either of the hospitals that I work at. So it's
Oh,
straight
okay.
to the doctor, straight to the midwife.
Okay, so that's incredibly important
Mhm.
because that means you're communicating with the doctor because the doctor is typically not at the hospital, correct?
It just depends. We have several different practices at the hospitals that I work at. So they are either at the hospital or they're close by at the office. Just depends on the practice. It also depends on what time of day it is. If it's night, often they sleep at the hospital just to be close by, or they will appoint one of the hospitalists or the house doctors to be the person that is available at the bedside until they can get there. So there's at both of the hospitals I work at, there's always an OB in-house. It may not be
Right.
the OB that you've hired, but there's always somebody in-house that can step in and deliver the baby. That doesn't mean that the nurses don't deliver any babies. That's a timing thing.
The
You
timing
come in
thing.
and spit out a baby, you might have a nurse delivery, but there will be a doctor there to make sure that everything's okay afterwards.
Oh, that's interesting. How have you delivered babies?
Oh
Sounds like you've
yeah.
delivered some
Oh
babies.
yeah.
Yeah, I like that.
Yeah.
That's interesting. What inspired you to be a labor and delivery nurse?
I think it was probably my own birth. Although when I was a postpartum nurse, I had the option before I got hired, actually, um, in New York, the hospital that I was at had several different programs for new nurses. And one of them was a little bit farther north than I wanted to live. And it was a smaller hospital. And they offered me the position, which was an LDRP position, which means that it's labor delivery. And then they would have postpartum on the same floor. So I would have been floating throughout. And I probably should have taken that position, honestly, because I would have learned a whole lot more. But I took the one in the area that I was more familiar with. And I was going to be down the street from my husband's cousin. So it just physically, I was 4 blocks from the hospital, and I was postpartum. But during that time, when I was postpartum, my mentor had said, I don't want you to be on postpartum for longer than 2 years. You need to do your 2 years, get settled here, and then you need to go to labor and delivery and learn that part. And I was like, oh, that's really interesting. Okay. I was gone because I moved to the DC area after 2 years. But when I was ready to go back to work, I kept a mental note of that and applied for labor and delivery nurse positions. And I'm really glad that I did because I had some wonderful mentors and it really put it all together for me. And honestly, being a labor and delivery nurse after having my first helped me heal from my birth trauma because surprisingly, even though I was a postpartum nurse when I delivered my first, there was so much I didn't know about the labor and delivery world. I thought I had prepared. I took the Bradley method class. I had a doula, but there was definitely something missing. In fact, I think there was 2 things missing. The first thing is I never got a debrief after my birth. So there was things that I didn't understand that nobody ever explained to me. I had to go back and piece it together myself. I got my birth records.
Wow.
I talked to the people that were training me. And it took me a couple of years to really come to terms and understand what really went down during my birth and why the choices were made that were made and why things were offered to me that I wasn't understanding why they were offered to me. I still think that I made the right decisions in my birth, and I feel like I advocated for myself well. But I think that it would have been nice to have had a discussion afterwards. Additionally, I didn't realize that mindset and emotional preparation would play so much into the birthing process. And so that's why I really try to make that a big focus of the birth prep that I do. And that's why I've become trained as a coach, because when you're really focusing on mindset and understanding what is underlying the decisions you're making, if it's fear that's underlying the decisions you're making, we need to kind of get to the bottom of that because that's going to come up so much stronger during childbirth and during the early years of the early months of postpartum. Because I don't think any of us understand exactly how it feels and how those emotions and that new relationship with your baby is going to feel after having the whole experience of birth and everything that goes into it.
Right. Yeah, no, and definitely with fear, fear's the unknown. The only way really to conquer fear is to have an understanding of, what you're walking into. And
Right.
that's
And
important.
it's important. And what I think a lot of people try to run away from some of those things, like knowing is one thing, knowing that you're going to get an IV if needles are your fear is one thing. But I see a lot of people running from that fear, trying to avoid it instead of dealing with it, instead of trying to figure out what the cause of that fear is and what questions could be answered to be able to put you at ease. And then continuing to dig deeper and figuring out why that's a barrier, why that's causing so much internal resistance, and why it's limiting your beliefs on what you can do in the birth space, and making it so that it might be potentially triggering when you get there. I try to focus a lot on what I see. Let me back up a little bit. I see people coming in with birth plans. A lot of the times they'll just download something online and they'll check off boxes and say, I want this, I don't want this, as if it were a menu. The problem with that is if you haven't considered under what circumstances you would accept some of those options, those tools to aid in delivery, then you really haven't created a birth plan. You've just kind of limited yourself. And what will happen inevitably, if you get to the point where those options might be the key to getting you to the birth you want, you've taken them off the table and you've just basically made sure that you don't get the birth you want. And so if we explore the reasons that those options don't feel safe to you in the moment, then we might be able to get you to the birth you want. There's never any guarantees, as you know, but we can use those tools to help you get exactly what you're looking for.
That's awesome because, I forget about the plans where you can check boxes because I'm a huge advocate of preparing a plan, but it's not so much for me, the plan in and of itself. It's the act of preparing. So you're right. If the act of preparing is just check, check, check,
that's not
boxes,
preparing.
that's not what I mean. If you've heard me say this on podcasts or on social media. But yeah, I mean, decision-making is huge in childbirth. I mean, this is all over social media, but I've said many times, families can be one decision or minutes from a healthy baby. And it's very important that those good decisions, are being made. And it's like anything in life. If you prepare, you're going to make better choices. You're going to make better decisions. You're going to know how to do something. And if you don't, then it's much harder to make those good decisions, with your delivery team or whoever. So I love that. I love that angle on prepping everybody. That's huge. And then, I don't know if you are comfortable talking with us on a podcast. If not, let me know. But your birth trauma, I mean, what can you give us a quick overview?
Yeah, I actually did finally share. I have an episode that talks about my childbirth. I don't know that I came at it from a place of trauma anymore, because I think that I've come to terms with that. And I apologize if you can hear thumping in the background. They must be getting the biggest part of the tree down. They're taking a tree down.
Lawnmowers. It's spring in Michigan.
So my birth, like I said, I prepared. I went to the Bradley class, which is the husband-led birth coach class type of thing. Not sure if that was the best option for me. My friend was a doula at the time, and she had a midwife friend that was teaching a class, and she wanted me to be prepared. And I really appreciate that. They talked to us about a lot of things. This was 9 years ago that I started preparing. So things have changed since then. There is and was a movement in the birth community that was basically advocating for a natural birth, which I don't think there's anything wrong with that. I think my approach is the birth that's best for you. And I don't know what that is. That comes from inside you, right? So in the birth class that I was training with, it was mostly trying to get us to advocate for a natural birth. So the approach was more defensive than I think is best for everyone. I think we have a culture now in obstetrics where the doctors and sometimes midwives are in one corner, medical providers, medical professionals are in one corner, and the doulas and the natural birth advocates are in the other corner. And I feel like we're not really communicating, and we're not paying attention to the patient that's in the middle. We're not coming together to try to figure out what's best for that person. And so that's where I come from as a birth coach. But in this class, we were focused on defending ourselves so that we could get the birth that we want. Nobody ever told me that my baby could potentially be at risk during labor and delivery. So my understanding was that the doctor would be pushing for a C-section because it was more convenient for them. And then they would use scare tactics like saying that there's something wrong with my baby. That's not 100% true.
Wow.
There can be things wrong with your baby. And it's your doctor's job to explain that to you. My doctor wasn't the doctor that I chose. It was the doctor that was on call because I wanted labor naturally. Lovely woman. I think she made the best choices for what she understood at the time and based on her practice. And I think that's the case for most physicians. They base it on their experience and making the best decisions based on their experience and their education. My daughter had a cord wrapped around her neck. She also had a 2-vessel cord. So that made it so there was less oxygen getting to her during the contractions. Ultimately, the doctor kept recommending a C-section. At some point, I needed to get my labor stopped after my epidural, and I can go back to that. I'm trying to summarize a little bit. And then we had to start Pitocin to get it to start again. Luckily, at some point, another person delivered. So when I declined the C-section, it was off the table for about 3 hours while we let the Pitocin do its job. And when I saw my doctor again, I was ready to push. I don't think I was listening to her heart rate. I don't know if I could hear it or not, but apparently there was a deceleration. Her heart rate went down. The doctor told me I needed to push quickly. She also said that she was making room for the baby, and we'll get back to that. And my baby came out initially floppy and blue, and she handed the baby to me. She had 0 tone, so she just felt like a bag of jello that was slippery, and I could barely hang on to her because I'd been pushing so hard and my arms were just like jello, and I felt like I just couldn't hang on to her. So I said, and the NICU team was there because of the decels. So I was like, just give her to the NICU team. And within a minute, she started crying. They stimulated her. Everything was fine. She didn't need to be resuscitated, but it was terrifying. I later came to find out when she said making room for the baby, she had cut an episiotomy. I was never told by her that she had cut an episiotomy. Yeah.
Wow.
Yeah.
That's
so there was no
problem.
consent there.
No.
There was no debrief or explanation. There were other things that occurred during the labor process that we can go back to, but that were less than satisfactory, that led to trauma. But ultimately, for me, the moments of handing me a baby that was floppy and blue, and later finding out that I had an episiotomy without consent, those were the 2 biggest sticking points for me that were hard to get past. As I process my birth, there's some other things that have come up that I've had to work through, but those were the 2 biggest. So I've gone back and looked at my records, and both of my babies, actually, their heads were transverse in my pelvis. And I don't know if it's the shape of my pelvis or the cord. Both of them had the cord around their neck, or what, that made their descent into the world so awkward. But that and the cord and the decels helped me understand how it might have been difficult for her to fit through my pelvis adequately, and would potentially require an episiotomy. So I don't necessarily disagree with her decision to cut an episiotomy. I think it was probably necessary given all of those things, which each one of those things is a potential indication. So there were 3. But I do disagree with the way that she went about doing it. If she had just said, for these 3 reasons, I think it's safer for you and your baby to cut an episiotomy, I would have said, okay, cool. But she didn't. She didn't give me the opportunity to consent. So that was an issue. And then obviously handing me a baby that's not responsive is terrifying.
Yeah. Yeah. Well, and that they needed to get going on that.
Right. Yeah.
I'm shocked they did that. Shocked.
Mm-hmm. Yeah.
Wow. So I got to ask you, C-section, you turned it down. Do you wish in hindsight at all that you wouldn't have, or you were good with
No, she was fine. I think it was a scare tactic.
Oh, okay.
Yeah. Ultimately she responded she had 99 APGARs. She responded within the minute. They just should have handed her straight to NICU. But I mean, whatever. We can't go back. The C-section, I think, would have. So what we did to determine if we need a C-section, and here's how I feel like we didn't need it. She was able to resuscitate intrauterine. Like, we were able to do intrauterine resuscitation, which is considered the safest route. Getting a baby out during a decel isn't necessarily the safest route because your baby hasn't had a chance to recover, and then subjecting them to the outer environment and trying to jump into extrauterine life isn't necessarily the safest. They were able to do intrauterine resuscitation. So I don't think that a C-section was warranted. I haven't had a chance to review my strip. I can't get those birth records. I tried. I don't really know exactly how to look at my strip. And I don't know if they had like Obix or anything where you can digitally see it. This was almost 10 years ago. But we did have a friend of ours who was an OB look at the strip in the moment. And he said, well, right now you don't need a C-section because your baby looks fantastic. And this was after they had offered it. And so we're like, look, no, I mean, right now she looks great. So let's just see what happens. And so then they offered Pitocin, and they went up very slowly. This I remember because I remember looking at the units on the pump. They went up in the first hour. They had me at 1. In the second hour, they had me at 2. In the third hour, they had me at 3. So they're very safe in their Pitocin.
Beautiful. I love that.
I do too. And that's all I needed. By then I went to complete. But the fact they were saying that I was failure to progress because I was stuck at 7 centimeters. And my argument was, well, I'm stuck at 7 centimeters because I was given terbutaline and my labor stalled out. So
yeah. Terbutaline, just so everybody knows, that slows your contractions down.
Yeah, it stops them. Now, most of the time it's out.
You're not going to progress if they're giving you terbutaline.
Exactly. Yeah. They gave me 1 dose, and normally your labor would kick back in, right? But I was like, well, what can we do to start my labor again? Let's just see. And if that doesn't work, if I'm still stuck at 7 centimeters when I have contractions, or she's not reacting well to the contractions, then let's do a C-section. So they were like, okay, let's try it. And everything was fine. But they came in when they saw decels again. And oh, lo and behold, I was complete and ready to push, because that is also a sign that you're complete and ready to push. So we pushed her out. I pushed her out in under 25 minutes, partially because they were concerned about her heart rate, but it was the cord, and it was the two vessels in her umbilical cord. And she came out stunned initially, but then after that responded beautifully.
Wow. So, that's awesome.
Yeah.
Good. And she wasn't like anemic or anything like that. Mm. Sometimes when that cord gets tight like that, it messes with the
blood
flow.
It was good.
Wow. So luckily then you had a basic understanding of the fetal monitor strips. So
little bit. We did consult with a friend that had better understanding.
Did you like send pictures, or did you
Yeah, my husband texted pictures.
Interesting. I get those pictures. As a childbirth attorney, I get the pictures. Oh,
Yeah, I don't know
no,
if he'll have them. He's not very good at saving. He doesn't have like the cloud. I'm obsessed with the cloud and making sure that I have all the pictures from
yeah.
baby four. But
See, that's nice that you did have somebody to send the strips to. The introduction to my book, they would send me pictures of the strips that the labor I talk about in the introduction. So that was like, oh boy. But no, I mean, I've had doctors testify that, really the only way the baby can talk to them during labor is through their heart rate.
yeah.
So, but I always feel like the medical community kind of wants to keep the heart rate to themselves. I mean, doulas are constantly like, I can't read the heart rate. That's medical. And I'm like, listen, as a childbirth attorney, it's the first thing I learned how to do. I walked in and they threw the baby's heart rate on my desk. I figured out how to look at it. We get the short course, but at least I knew enough, at the beginning. Actually, it probably took like an hour and a half to get everything down. But no, I included a chapter in my book on how to read the fetal heart rate because it really is a good indication on how your baby is doing, especially if you have something like a Pitocin induction, which I love your Pitocin induction. So was that just their practice slow and steady, or was it specific for you? Because sometimes if there's concerns about the baby, they'll keep it. I mean, you're the labor and delivery nurse. I don't need to tell you that. But
I don't know I don't know at all what the protocol was at that hospital. I feel like it was a pretty low dose protocol.
Okay.
Hospitals that I work at now, I was shocked when I started and they said, okay, we go up by 2 every 15 minutes or every 20 minutes. I'm like, that's too much.
Oh,
but
yeah, you know what? This is why, I mean, I have a whole chapter on how to be safe Pitocin induction, but one of the biggest things is talking to your doctor during your pregnancy about it, because if somebody, at this point, my grandkids, my daughters, if they're like, we're going up by 2 every 15 minutes, I would have a heart attack. As I don't know if I've said it yet, but Pitocin is one of the most common issues or facts in a legal baby case. So when something goes wrong, baby's not born healthy, Pitocin is most of the time being administered. So it's very, it can be administered safely, and it might be a great option for a mom, but you just got, again, you've got to be ready. You got to prepare. So you tell everybody, I mean, in the hospital, I mean, I'm always jumping around about Pitocin, but now we have a labor and delivery nurse on who, I mean, you're following the doctor's orders. You're really running the Pitocin induction. Can you tell us a little bit about that? Just running the pit induction?
Yeah, well, luckily now we have a Pitocin checklist. So we have to check off the safety standards now to be able to go up on the Pitocin. And there've been just so much back and forth between the providers and the nurses. Like, why aren't you going up on the Pitocin? And the nurse is not feeling safe, and the nurse is calling the providers because they don't feel safe, and the providers like, why are you calling me at 3:00 in the morning? There's just all this. So it's a form of communication, I think, where if the nurse goes through all of the checks and everything checks out, then you can go up on the Pitocin. There's a little bit more leeway. It doesn't have to be like wham, bam, every 15 minutes. After 15 minutes, you look back on the 15-minute strip, you answer the questions. Then you decide if it's safe to go up on the Pitocin. You click yes, you go into the room, you go up on the Pitocin. So there's a little bit more of a delay. I usually involve like a position change, or I talk to the patient about how they're feeling. If there's like no reaction, they're basically just sitting there chilling, watching TV. There's no, they're not feeling a thing. I'm like, okay, yeah, let's go up on it. I always at 6 start to reconsider what we're doing. I'm like, okay, we're at 6 of Pitocin. You're not feeling anything. What's going on? Let's get up and move around. Let's figure out, you should be feeling something by now. It's been a little over an hour.
That's interesting. Why is 6 your magic number?
That's the physiological, or the dose that mimics physiological labor.
Yeah, it's in my book.
I know.
I was going to look. I'm like, I think it's 6.
It's 6.
So if you go to the Pitocin drug insert, it's like, 6 should mimic your spontaneous, contractions that you should have. And actually it says don't even go over, only in special circumstances should you even go over 9 or 10. And whatnot. So it's, I feel like it's very different than how a lot of doctors, write their orders. And then I even recommend in my book. So do you guys, I assume most of your orders, the initial one goes to 20?
Yeah. I think it's notify the provider at 20.
Yeah, notify, and then if they want to keep going past 20, then they need another order for 30. Yeah. So I am like, breaks. And I'm like, you're going to talk to your doctor during pregnancy about your Pitocin induction. And I recommend stopping the order at 10. Why? Because you know what? If anything, and listen, everybody, this, but everybody responds to Pitocin differently. So, somebody may be more sensitive to it than somebody else. But anyway, I'm like, hey, at 10. And then that at least has the delivery, doctors coming in, checking everything out or whatnot. So,
I usually talk to the provider when we get to 10. I'm like, hey, we're at 10 of Pitocin.
Oh, see, I knew
there. What do you want to do?
Yep, you're like the best thing since sliced bread. I hope everybody
by
gets
then. What I don't want them to break their water at 20, and then put an IUPC, because then we got too much pit, and then we're just setting ourselves up for distress. So if we're going to move the labor along, and one of the ways to continue to move the labor along is to break the water. If it's not broken already, that might be something we consider, because it brings the baby's head down in the pelvis. We make sure that we do it safely, but that is something that can be offered. Now, I realize that also potentially comes with complications, but it's one intervention that can move us closer to physiological labor. And if we're past 10 of pit, I find that usually what happens is I need to back off a lot on the pit. And the reason I find out that I need to back off on the pit is because either the mom can no longer handle the labor or the baby's in distress. And so either way, it would be great to be able to just, get that barrier out of the way and see at a lower level before we move forward with the rest of the induction. The other option that I see a lot of providers recommend, which if this is what the mom is wanting, getting the epidural first and then break the water. And then we move forward. So we leave it at that number, get the epidural, break the water, and then we can back off if we're having too many contractions or if the baby's in distress. But I pretty much always have a conversation with the provider at 10, just because it's like, well, here we are. What are we doing?
Right. That's huge. That should be required. I think
so.
Too, the doctor's order should be 10. Yeah. And, you're smart. So, and you're a really good nurse. So that doesn't surprise me that at 10, you go and talk to the provider. But, there may be other labor and delivery nurses who are just, maybe they're going to be great, but they're new. They're newer to the, the show. So it's like, I talk about this in my book. I had 2 nurses on a case. First nurse, oh my goodness, amazing. Born to be a labor and delivery nurse. She had been one for 20 years. She was absolutely amazing. And my other nurse that was in that case, she had just finished training. She had just started getting patients where she was managing them on her own after training. She quickly figured out she hated labor and delivery and was looking for a different job. But a lot of times when patients walk in, it's like luck of the draw. Which one are you going to get? And the only reason the born to be labor and delivery nurse was drug into the case is because she was trying to help the other nurse. So, it's definitely luck of the draw. But, the point of that story is, understanding a Pitocin induction. I can tell you, new labor and delivery nurse, the one that hates her job, she would be the one that's just going to follow the orders and whatever. Born to be labor and delivery nurse, she did have to get involved because that, whatnot, but she's going to have better judgment and whatnot. So your hospitals where they want to increase it by 2 every 15 minutes, do do you follow? I mean, is it just very individualized with your patients, or how do you
Yeah,
run
I
that?
usually will go in, encourage them to move around more, then judge or ask them what their pain scale is, where they're feeling it, what they're feeling. Um, and then I'll slowly go up. I don't usually, I try to stretch it to 30 because it just, I mean, the insert says that it doesn't even really hit your bloodstream until like 30. So why are we going up every 15? But I assess every 15 minutes. Not even, I'm always assessing. Like I'm literally always watching the strip. It's a
Yeah.
constant assessment.
Well, once PIT's on, though, you're required, it should be a hospital protocol, right?
Mhm.
15 minutes once PIT's on. How many
Oh no,
patients?
constantly watching.
Yeah. Well, how many
Regardless.
patients do you have in, I should say, active labor? And I don't know if you guys are just, how many patients do you have at once?
Usually two.
Usually two?
Until we, I mean, it just depends on the day and how busy we are.
Right. But you
There's always an
can.
attempt to have somebody that is in early labor and then another one that's in like either on Pitocin or closer to active labor. At some point, you're going to give up the patient that's in early labor so that you can push with the patient that's ready to push. So I wouldn't necessarily have two patients if I was pushing, or if I'm getting an epidural, if I'm doing something that requires, 1-to-1. But often I have two patients while I have somebody on PIT. I don't necessarily always have two patients on PIT, but that also does happen.
You
So
have
it just
two
depends.
patients, you're running a Pitocin induction.
Mm-hmm.
So that's interesting. In chapter 14, I'm like, you want to find out, is it one-on-one with a PIT induction? I prefer one-on-one with PIT inductions. Actually, there's hospitals that if you have a patient, once active labor hits, is that what, over 6 centimeters?
Mm-hmm.
And then that's it. That nurse has one patient. That's it.
Yeah,
So, every all the hospitals, they vary in the way
they
that
do.
they handle it. And, but again, if you have a really good nurse who can juggle and do stuff, that's just going to be so incredibly important. I mean, two patients on a PIT induction, like freaks me out.
Yeah.
Obviously.
And it's not always, it's not always that there are that many nurses available. There is a lot of, at least in my area, there's a lot of turnover with nurses because like people move away. In DC, there's a lot of people coming that are just here for a little bit of time because their husband's in the military or a government job or whatever. There's just a ton of turnover. So retention is across the board difficult at hospitals in our area. I don't know how it is in other parts of the country. I know that there are, especially in California, the nurses have worked very hard to unionize and follow A1 standards for staffing. And A1 does recommend 1-to-1 staffing for Pitocin and I believe active labor. Certainly for an epidural and for when you are ready to push. But it's just a matter of, physically how many nurses do you have?
Yeah. Right. That's I know. And with the busy, the units, I mean, that's the crazy thing. Babies want to come when babies want to come.
Right.
So do you guys have busier times of the year or day on your unit?
Yeah.
What's
Summer.
your busy year? Busy time of the year.
We're coming into it.
So that's Michigan. That's interesting. Michigan's
Yeah.
the same thing. May, June, and July. That's the busy. And then are you busy like more like late mornings?
I don't know. Yeah, it's like if overnight they've been busy, then the early mornings are very busy, like everybody's delivering. Later in the morning it does get busy because most people have their scheduled induction and then they're more likely to pay attention to their labor pain when they get up in the morning and it's been going all night and they're just like, okay, yeah, no, this is real. We're gonna go.
Yeah. Interesting. So you guys are the same. Just remember that, everybody. May, June, July. Well, and a common issue and common fact in the baby cases is a busy labor and delivery unit. That's, and they may have a great team. But when you guys are jammed, I had one, it was, it's similar, like the in-house attending was kind of taking care of everybody, private's on the way, but the in-house was so incredibly busy. the eyes were off the prize for a little bit, and it wasn't good. But in that part of the book, I'm also like, listen, but if you understand things, or you have good understanding of baby's heart rate, or you're ready for childbirth, sometimes if there is a concern and you know that it could be a concern, like something with baby's heart rate, if you're able to grab the team and be like, hey, I'm concerned, more like if the baby's heart rate stops graphing, there had been concerns about baby falls off the monitor. If, you go and get somebody, they'll put baby back on the monitor, stuff like that. And then obviously if there's any concerns, the team is going to be lined for you versus maybe mom who stalled out in labor. So yeah, busy labor and delivery units is, that's huge.
Well, something that cracks me up a lot is, I don't know if you remember the nurses playing cards thing that they had talked about several years ago. That all the nurses in the US were up in arms. But we have a lot of people that come to the desk, families that come to the desk, and they'll see all the nurses sitting, looking at the strips, saying, "Oh, you guys aren't very busy." And we're like,
we're watching your
do you
baby
see
very
all these
closely.
people? Do you see all these lines? We're a telemetry unit, essentially. We are, I mean, on telemetry units, they pay people in offices to sit with the remote strips and watch and alert the nurse when something is going on. We are that person in labor and delivery. We're watching the baby, we're watching the contractions, and we're watching the whole floor, because if I see my coworkers baby is doing something, or if somebody hollers out for help, then we absolutely will all go running in there and help move the patient around. So it's not that we're not doing anything, it's that you don't want us to be going crazy.
Yeah. That's yes. I wrote that in my book. I was like, watch your delivery team. Are they a little panicky? Do they trying to move fast? And some stuff.
Yeah, get out of the way if that's the
nurses
case.
playing cards on labor and delivery would be complete. That would never happen, by the way. Like, no, you guys, one of the questions I wanted to ask you was, I mean, how do you mentally prepare to go to your job every day? I mean, you're 12-hour shifts.
Yeah, I just kind of just jump in and do it. It goes by pretty fast. I mean, well, the thing is, sometimes it's like if nobody's there for their induction yet, it's like twiddling your thumbs. Then it's like, what can I do? Okay, I've got all of these education modules that I have to do. So you'll see us on the computer doing those, or going around doing the stat strip checks, like for the blood glucose monitor, making sure that that's functioning, walking around trying to figure out, but yeah, eventually it does get crazy, pretty much every day. So yeah, I don't know. I used to sleep a lot to mentally prepare. I think I'm just kind of used to it at this point.
Yeah. Interesting. So one of the things, again, I talk about in my book is the delivery team. Like, you're such a big part of that delivery team as the labor and delivery nurse. But I mean, really, you guys are responsible for bringing baby into this world safely. So and it's always the delivery team's care that's at issue in the cases and whatnot. So in the book, I'm like, okay, these are people who could be on your delivery team. And you want to make sure you have a good team. You want to make sure you have a good nurse. And if you don't have a good nurse, you're going to have to say something, again, going back to advocating and whatnot. But I mean, how does somebody know, an expectant parent or whatnot, if they have a good nurse?
Does the nurse listen to you?
Yes.
If someone's telling you what to do,
I like that.
It's time to reframe the situation. Something that I work with my clients on is how to communicate with the delivery team. In the hospital, we are trained to use, there's a model called Team Steps, and they say to use your cuss words, which is, I'm concerned, I'm uncomfortable, and this is a safety issue. And that's how we get the team to listen in a way that is non-threatening. So if you talk to your doctor and you come in and you say, you know what, I'm concerned about this strip, and then you state why, they're more likely to listen to you, because you've given them a word that like makes their ears perk up. If that word doesn't work and you're still concerned, if their response isn't satisfactory, then you can move on to, I'm uncomfortable with this. Can we do something about it? Like, maybe let's try this and this and this. Would that be okay? And then if still that doesn't work and you're still concerned, then you can say, you know what, I feel unsafe. This is a safety issue, however you want to word it. Once you use the word safe, people aren't going to ignore you anymore. Because if you feel unsafe, then somebody's going to fix that. It's very, very hard for someone to ignore the word safe. With my clients, I will say, of course, if you feel unsafe, say that you feel unsafe. But if you are still kind of not sure what they're trying to communicate with you, like if they're trying, like for instance, when they were trying to tell me I needed a C-section, some of the most wonderful patients I've had that were the best advocates for themselves have said, am I safe right now? And is my baby safe right now? If the doctor says, yes, you and your baby are safe right now, I'm trying to prepare you for what potentially could be happening. We don't need to move forward with any of this right now. Then you can take a breath and you can sit with your decision and try to figure out how you're going to move forward. Wrap your head around it. You have time to emotionally process. If they say, no, your baby and you are not safe right now, we need to move immediately to the OR. My advice to you would be, then say, okay, let's go. Because if a provider is that concerned that they would absolutely agree that you and your baby are not safe right now, then I can't think of any provider that would be lying about that and just trying to get you to go to a C-section for no reason.
Wow. What you said is so incredibly important. That's awesome. And I like how you started the story. You said you have the best patients that know how to advocate for themselves. But can you shed a little bit more light on that? When you're saying they advocate for themselves or they're just asking the right questions, what are they doing?
Yeah, in a manner that is non-threatening. I think like I said, it takes a lot of emotional preparation to get to that point. Because if you're coming in from a place of fear, you're not going to be communicating well. You're going to be jumpy, reactive rather than responsive. It just sets up a power struggle, because if patients seem nervous about everything, then the provider feels defensive. And I don't think that going into the labor and delivery scenario with whether you're a provider, you're a patient, you're a doula, being defensive is ever a good thing. That sets everybody up for failure. That when you're defensive, it means it communicates mistrust, and that's just not a good thing. You need to be working as a team, and the only way to work as a team is to have trust in each other. So that starts with preparation. And by preparation, I mean, like, you start making sure that you have a provider that you align with, that you feel safe with, and that you trust. And then you find a birth team that you trust and you align with. You get a doula that understands your birth preferences and what your limits are, when you would be open to some of the interventions that aren't considered natural. You need to make sure that everybody understands any medical complications that you may have and what that might mean for when you would choose different interventions. Because if you have medical complications, it might be sooner that they would consider you or your baby to be unsafe. So getting ready doesn't just mean understanding those things. It also means understanding how you feel about those things. If you're going in fearful, if somebody mentions something like an IV, an epidural, breaking your water, any of those things, and you're terrified of it, we need to get to the bottom of why you're terrified. I've had clients that say that they're terrified of cervical checks. And while you can decline a cervical check, and when somebody comes in natural labor and is crowning, we probably don't need a cervical check. It is a good way to gauge where we're at. And especially if you have medical complications and you need an induction and we're starting from scratch, your provider will need to know where you're at. And if you need cervical ripening or if you need Pitocin, that might require a cervical check. So then we need to talk about what it is about that cervical check that's going to cause fear. Some people I've worked with have had cervical interventions like cervical procedures like a colposcopy or pap smears that were painful, or they've had an IUD placed and that was painful, and they're likening a cervical check to those procedures. And while cervical checks can be uncomfortable and sometimes even painful, you don't need to subject yourself to all of that pain. I think people don't realize that you can consent and you can also withdraw consent. And if you're getting the cervical check and it's too painful, you can use a word that's very powerful: stop. And if you say stop, a provider needs to stop because they're doing something to your body that they no longer have consent from you to do. And then you can say, I need a minute. This is a lot. A lot of times, if we can't get to your cervix, that just means that we need to do some cervical ripening. So if they've attempted to get to your cervix and you say stop, probably the next steps are cervical ripening. And then we can move forward. Usually by the time your cervix has thinned out and opened up a little bit, it's a lot more comfortable to do a cervical check. I've had patients, though, that come in saying that they want us to check their cervix with a mirror. I'm not sure if that's something that happens on Facebook or Instagram or TikTok. I don't know where that came from, but that doesn't tell us really anything.
Oh, that's interesting.
You can't.
I feel like I've heard the mirror thing before, but
yeah, we use the mirror to be able
context.
to like get out external feedback when pushing with an epidural. So or just pushing in general, if you don't believe that your baby's head is right there or that what you're doing is working, a mirror, like a glance at a mirror while you're pushing to be able to see that your baby's head is descending when you use these muscles, can be all the difference that a patient needs to be able to push the baby out. I don't know about cervical checks. I would really love an answer to how to check a cervix with a mirror because I have no clue. Usually it does require some manual checking. And if it's too painful, if it's too much for you, absolutely you can say stop. Some patients, especially if there's been sexual trauma in their past, will opt for an epidural before they have the cervical check. Usually those are very extreme cases. But if it's something that is that traumatic for you, you don't need to endure it. And I've also met people that have had C-sections because of past trauma. Also, if that is something that you require for your birth, that's something you would want to consider. That's why you prepare for it. You ask yourself those questions, like what you are emotionally prepared for, what feels safe for you, and you make the decisions that make you feel the safest, because we're not trying to cause trauma in childbirth.
Right. Wow. That is such powerful information. Sometimes every time you talk, I'm like, yep, I like her so much.
Well, didn't you? I can't remember. Did you say that you chose a C-section because of everything you knew, like all of the things that you had been through, or was that a friend of yours?
I
don't remember.
Yeah, that's me. No, so I had my first baby in 2004. In 2004, elective C-sections were not really acceptable. So as childbirth attorneys who cannot relax, because unlike you get to see the good. I'm kind of jealous. I only see the bad unless it's a personal story. Those are a lot of good ones, and those are the ones I always try to focus on in my book with the good outcomes. Yeah. So anyway, no, we can't relax. So back in 2004, you had to tell your doctor you had genital herpes, and then you would get your elective C-section. So she did. She got her C-section, and she's like, "Come on, just then go to my doctor and tell him." Because my doctor, I'm like, I'm not telling my doctor I have herpes.
Yeah.
And so I'm like, I'm persuasive. I'm an attorney. And he was pretty stubborn about it, which I could have gone. But, I'm like, I just kind of kept going back and forth. I hadn't experienced it, I mean, when I was hired in, I'm hired into a team of over 20 of us. And this is all we did were baby cases. So I'm like, I just don't want it to happen to me. But it's also, again, relax. I can't. I couldn't relax. That was more of my issue. And you know what? So he just kept pushing me off. I woke up in pretty hardcore labor, and went to the hospital, and yeah, a couple D cells. They're like, just give her C-section.
Baby
So
declared itself.
yeah. So, and then obviously my next two were elective C-sections, but the mental psyche between going into labor versus rolling up for an elective C-section is crazy. You don't have those cues from your body, like get the baby out, get the baby out. You know, you're just sitting in the waiting room looking down going, okay, let's do this.
Well, it's
So,
really hard to go into natural labor and deliver if you're stressed out. Stress actually stops the natural Pitocin.
Right. So I think
like,
so that makes sense. Interesting you
yeah.
say that, because I was sleeping. So I was pretty relaxed. I was obviously super tired to sleep through so many contractions. But then once I woke up and freaked out, then I think that was it. So, okay. I would just there was one other question. So when we're going back to, knowing good delivery nurse, I love listening. That's huge. And it's almost like, I almost know the answer to this, but is there any like red flags when it comes to a labor and delivery nurse, like a red flag and like this might not be the right nurse for you?
If you just feel overly uncomfortable with someone, you can just ask I feel like it's better to ask early on if you can switch, than wait until it becomes a problem. The reason I say that is because I don't know that there are bad labor and delivery nurses. Just like I don't think that there are necessarily bad doctors. I think they can be the wrong ones for you. I think people can make bad decisions in the moment. But if that person that is in your delivery room makes you feel uncomfortable, and every time they walk in the room, you feel uncomfortable, I would just say, see if you can switch. And when you do, ask for the charge nurse and say, you know what, this may be more about me than it is this person. I'm sure this is a wonderful person, wonderful nurse. For whatever reason, I feel uncomfortable when he or she walks in the room. I'm not sure why. Or if you do have a specific piece of feedback, you can share that with them and, try to do it out of love and kindness, because I don't think anybody's trying to be a bad nurse. I think feedback that people can learn from and improve from is the best kind of feedback. And the reason to be kind is they don't always have another nurse for you. So
good point.
Sometimes it's possible, sometimes it's not. So just, if you're feeling uncomfortable or for any certain reason, voice your concerns to the charge nurse, ask them to be discreet, ask them to be kind, and say, this may just be me. If there's another nurse, great. If not, maybe we can get off on the right foot again. Maybe we can try again. There are definitely patients that I've walked in the room and there's been a vibe that I didn't quite flow with. Usually what I do is try to back up and reflect and see if I can just come in, and I try to like rein in my own persona. Just come in quietly and move quietly, and then try to read the room. And then usually we will get to a point where we kind of mesh. But I have had patients that just didn't like me from the get-go and said, I don't like her, I want her out of the room. That's their choice. I try not to make that about me. I check myself and I try to see if I went in there with a certain energy that was maybe not the best, and I try to change it. But it happens. And if you don't feel comfortable with any of your providers, you are absolutely welcome to request another provider.
Yeah, I can't imagine that, someone not liking you, but
okay. Thanks.
I'm like, that would hurt themselves. Anyway, but I won't go there. But yeah, I think that was really, really good way to handle it, for sure. So I do have one more question, and I think it's going to be the question I end each and every podcast with. But what is one piece of advice that you could give expecting parents or even expecting grandparents, whoever, one piece of advice for a safer childbirth?
I want to say listen to your intuition. And I want that to have a caveat of prepare emotionally, because if you're listening to your intuition and you're not digging deep into what it is actually telling you, then you may not be going down the right path. So listen to your intuition and try to discover exactly what is beneath it, what it's trying to tell you. Figure out where the feelings are coming in your body, where what your experience has been in the past that may be causing them. And then learn to make those decisions that sit well with you so that you can decide when you would be open to certain tools in the labor and delivery space so that you feel like you're making the correct decisions, and then go from there. If you've done all of that, you're coming at labor and delivery with a place of confidence and calm and trusting yourself. So when you're making decisions in the moment that might be stressful, you know that you're doing what's right for you because you've done all of that work ahead of time.
Perfect. Perfectly said. I 1000% agree. Where can my audience find you?
You can go to kellyhof.com. I am currently changing up my website, so kellyhof.com is where it's going to be. You can also go to kellyhof.com/empowered, where all of my birth coaching stuff is. But eventually my main page is going to just be kellyhof.com with all of that stuff. So either place you can get to it, but know that I'm a little bit under construction right now.
That's awesome. And they can also follow you on Instagram too,
yeah.
right?
Yep. At Kelly C. Hof. It's one F in Hof. Kelly, C as in cat, HOF as in Frank. I'm also on Facebook. And we're doing this together. We have the Bump and Beyond vendor event that we're doing together, which is a place for moms and moms to connect with resources that can help them during pregnancy and beyond. So that's another place, because it's not just me, it's a whole bunch of other people that are dedicating their lives to help new moms.
Love that. Well, thank you for joining us. I know in the future you have to come back on the show.
Absolutely.
We'll change up our topics, but I think us pairing together is it's a good thing for expecting parents to make sure they, to help them have a healthy baby. So thanks again.
Absolutely.
For being here.
Yeah. And you need to come back on mine. we'll come up with all the topics.
I love it. I love it. Thank you.
Yeah. Thank you.
Thank you, everyone, for tuning in to the Childbirth Attorney podcast. And I hope you enjoyed my conversation with Kelly Hof today. She is an amazing labor and delivery nurse. And I love everything that she said in our episode. So anyway, make sure if you're watching this on YouTube, you subscribe. On Instagram, you can follow me at Gina Mundy. And my website is always a great place to reach out to me, to see what I'm up to, check out my resources, ginamundy.com. So until next time, take care, hug your little ones, and enjoy every day.